can change that number that's, again, pathetically 2% for women and even less for people of color. And everyone here who wants to invest, just keep that in the back of your mind. There's like really great opportunities out in the market that you can take advantage of. And I want to thank the panelists. This was awesome.
Nice job.
Thank you. Thanks.
Awesome. So, when I just came back,
Hey, how are you? I'll see you in
We're so happy that everyone is making connections here. Is this working? Yes. Hello? 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 We're so happy that everyone's making connections, but if those of you who are from the previous panel are still in the room, you are now in our way. I encourage all of you talking to take your conversations outside. Thank you.
So then you go back.
So we're just going to go ahead and get started. Welcome, everyone. It's really a privilege for us to be back here at the Yale Innovation Conference to talk about mission-driven innovation. My name is Maxwell Laurans. I'm the Vice President of Surgery for Yale New Haven Health and co-director of CBIT, the Center. Thanks. Pretty good at maintaining focus with distraction. That's like co-faculty director of CBIT, the Center for Biomedical Innovation and Technology for Yale. We're thrilled to be here, and we have a remarkable panel to share some of our thoughts about innovation from a health system perspective. And what's important as we think about how healthcare is changing and changing around us in real time. I'm going to ask each of the panelists to briefly introduce themselves, and then we'll go into a little bit more depth. The goal here is ultimately to make this interactive and take questions from the audience. So we'll do what we can to get through a few questions to give you a sense of what each of these individuals has been working on over time, and then we'll open it up for questions. Before I get going, could I just get a sense, just so we understand a little bit who we're talking to, if you would consider yourself an investor, would you raise your hand, please? And if you'd consider yourself a clinician, a student, faculty, any other big groups that I might have missed? Founder and entrepreneurs? Great, thank you. Thanks very much. I think so. We've got a broad swath of folks who are focused on innovation in healthcare, and that should make this a really interesting and dynamic discussion. Pam, maybe just start with you, if you don't mind just introducing yourself and a little bit about your background.
And I'm sure to offend everyone now that I know we have such a diverse group of people, so that's always a good thing. Good morning, my name is Pamela Sutton-Wallace. I'm currently serving as the Chief Operating Officer for Yale New Haven Health. Most of you probably know Yale New Haven Health has, I would say, 7 campuses, 5 delivery networks, a host of ambulatory care networks. We're a $6 billion organization. I've had the privilege, though, to serve in a number of academic centers. I've been in academic medicine my entire career. I've worked at Duke University Health System. I've worked at University of Virginia Health System, and I've also worked at New York Presbyterian Health System. So it's been nice because I've been able to see several different models of what we consider to be an academic medical center, all 3 of those of which invest significantly in innovation. So happy to bring that perspective.
Thank you.
Good morning, everyone. My name is Amber Childs, and I really love how you led about talking about service. I think that that's so aligned with a lot of the work that I do in particular. I am a child and adolescent clinical psychologist, and I'm an assistant professor in the Department of Psychiatry. I also am a psychologist at Yale New Haven Psychiatric Hospital, and my role there is really as the co-director of what's called the Division of Quality and Innovation within Yale New Haven Psychiatric Hospital, really focusing on making sure that the evidence-based practices that we know are helpful and effective for people in behavioral health are getting to the populations that need them, and really thinking about innovative strategies to get that done. I also direct the psychology doctoral internship program, which is in the Department of Psychiatry, and just found out that we're ranked number 4 in the country, so which really exciting news. And I am also a founder. I'm going to be speaking a little bit about IMSelect today, but I also am the executive director of what's called the Getting Racism Out of Our Work initiative, which is really designed for clinician leaders and supervisors to help them become racially and culturally responsive practitioners and educators. So do a number of different roles, and happy to be here with these panelists.
Honored to be here. My name is Emily Gilmore. I am a neurologist in training and a critical care neurologist at that, and also trained in critical care EEG monitoring. I co-direct the neurotrauma program and direct the neurosciences intensive care unit and direct the neuromonitoring program, and have several other titles in which all are focused on actually delivering the best care possible to patients. In addition to research and participating in clinical trials and running clinical trials, I have an R01 in traumatic brain injury. I also am a steward to bring technology and advanced care to our health system. As the flagship hospital for the health system, we have a state-of-the-art neurosciences intensive care unit, and have integrated over the last decade or more of being here all the available technology that the field can offer for brain-centered resuscitation. And the application that we'll be talking about today is just a small part of that puzzle. And I really value being up here with this group and the opportunity to actually transform the way in which we think about delivering acute care and guideline-based care so that every patient at every delivery network within our health system gets the same access to care.
Just one clarification. Emily is a critical care neurologist by training, not in training. And completed her
Yes, I guess my MD is.
Good morning, everyone. Jinlei Li, I'm an associate professor from anesthesiology. My daytime job, I hide behind the blue screens and work with the surgeons. You don't get to see me. But in addition to that, I run the regional anesthesia service at Yale New Haven Hospital, so I have lots of practical experience managing acute pain, and that's why I'm here. We want to share with you our project.
Hi, everyone. I'm Dan Wiznia. I'm an orthopedic surgeon. I focus on hip and knee replacement, and I'm also the director of technology and innovation within the Department of Orthopedics. Part of that role, I help roll out new technologies at the hospital. We just rolled out a new robotic joint replacement technology at the hospital just a few weeks ago. So, I just want to thank, to have the opportunity to share our work, and really hope you enjoy the session.
Well, why don't we just start right down there and come back? And Dan, maybe you talk just a little bit about the innovation. So we're here to, your clinical backgrounds are critically important and inform your decision, but maybe just, if you could do the 60-second elevator pitch for your innovation.
So I'm going to have Jinlei Li do it because I'm going to have to leave early. I have to actually do a case, so I'm going to have Jinlei Li do it.
The life of an innovator and surgeon. Okay.
Now you see the dynamics, right? All right. Thanks, Dr. Laurans. So our medical device is called Patient-Controlled Dispenser Deactivator of Oral Liquid Medication. We call it PCDD. With the support from Yale venture directors, we started with Richard Anderson, Marak Grassi, and of course Jim Boyle is behind everything. We filed 2 provisional and 1 utility patent. With the Yale New Haven Hospital supports, of course, Dr. Laurans, and with Walter and Margaret, we just had our contract manufacturer in the Silicon Valley got into action with the design and the production of the first generation device for PCDD. So PCDD has 2 components in it and has different impacts. The first component is a dispenser. It mostly impacts direct patient care and healthcare system. It provides instant access to the patients of oral liquid opioids, allow patient-controlled self-administration without a nurse around. So you can imagine the impacts on nursing, on patient satisfaction, on the hospital length of stay, and economics from the healthcare system. The second component is a deactivator. What that means is the healthcare workers, the patients, can simply press on the PC button at the end of the treatment, deactivate all the unused medications. This can minimize diversion in hospital and at home. And you probably don't know this number, but it is striking. Nearly 90 million opioid prescriptions each year in the United States, they're not finished. They're in the household, and it's our goal to continue to use the PCDD. Eventually, there's no loose pills in the community to be abused, to leading to death. With the help from Yale Ventures and Yale New Haven Hospital, our group want to be bringing to the market the very first patient-controlled oral opioids dispenser and deactivator.
Thanks, Jinlei.
Yeah. So our program is the mobile resuscitation application, and probably is a little bit different path than what you're going to hear up here, in part because we're not on the path to establishing a company. The current state of resuscitative care in hospitals as it exists now is a team responds at the bedside when a patient has a cardiac arrest. That documentation is done on paper, believe it or not, in this day and age. And although there are a couple applications that exist to to provide support as a co-pilot of sort to ensure that providers are delivering guideline-based healthcare. It's not integrated with the electronic health record and thus still requires editing and double documentation, is prone to error, and is not immediately available to the clinical team then picking up that patient in the intensive care unit and understanding what happened to them. And so we pitched a mobile resuscitation application that was then supported by Yale Innovations and Yale New Haven Hospital to then partner with Epic, which is one of the largest electronic health record systems in the country, to develop this application within Epic. And so we forwent the IP and have partnered with them to develop this application that will function for providers at the bedside as a co-pilot with metronomes and guideline-based metrics to ensure that every patient is getting guideline-based care. And then we'll integrate with the electronic health record to be immediately available to the clinicians picking up the care of that patient after the arrest. This is an iterative process in which they have partnered with us, so as this will be one of many applications we hope to deploy with them. Our goal is stewards to delivering care, not just the best care possible at Yale New Haven Hospital and its delivery networks, but was to have a reach nationally and globally because of the footprint Epic has in the landscape of healthcare. And so we've actually moved relatively quickly, and within 10 months have a prototype. Epic will be back on site in 2 weeks to trial that prototype that's on a handheld device with our stakeholders for feedback. And so we couldn't be more excited and grateful for everyone's support. Margaret Walter especially has been just an incredible partner in this process, and are grateful for the opportunity to be here.
Thanks, Emily. Amber?
Really starting that trend so that I can get some applause after I talk to you. It's really exciting to hear about the work that's being done. So as you all may know, if you've been paying attention, there is a youth mental health crisis that has really unfolded and has surged within the past 2 years. And so if any of you are former teenagers in the room and have experienced yourself any sort of mental health challenge, you know what the cost is for that mental health challenge, particularly if you were not able to receive the treatment that you might have needed to get the support to be able to move forward. So later on today, I'm going to discuss what the economic cost is of that, but I think it's really important for us to really think about what the actual lived experience impact is. And so as you all may know, most teenagers are not getting the evidence-based treatment that they need, the treatment that we know is able to reduce their symptoms and also improve their outcomes. And so even if a teenager actually gets access to that evidence-based treatment or that provider, many of you may not know this, but 28 up to 70% of teenagers drop out of treatment. So if we actually even get them into care, the treatment dropout rates are absolutely staggering. So the innovation that I have developed is really thinking about how do we make sure that teenagers are getting the best treatment in a way that's actually resonant with that population. Teenagers are not going to sit down for 45 minutes face-to-face with you and I and have a really in-depth conversation across the board. Some might do that and some may need that, but it might not be the solution for everyone. And so we've really thought about how can we get treatment into the pockets of teenagers, under their pillows, at their bedside tables. What you're probably thinking about is exactly right. It's going to be on their cell phone. And what we know is when we use evidence-based, clinically proven treatments and we incorporate a routine measurement practice to that evidence-based treatment, it actually amplifies the benefits of that treatment. So what ImSelect does is it provides data-driven, brief, personalized interventions right where teenagers are most likely to seek out help, which is right there online and on their phones. But that data works hard for teenagers because we don't want data going into a black hole. If we get data from teenagers, we want it to be to their benefit, but also to the benefit of their caregiver who needs psychoeducation and support to best support that teenager, but also any clinical provider that might come into contact with that youth, which is most often not a psychologist like myself. It's most often going to be a primary care provider, if in fact they land with anyone at all. So those data, along with clinical decision-making guidance, is provided to primary care providers and psychoeducation to caregivers. So it's really really connecting the dots for everyone in that teenager's care ecosystem so that we can improve outcomes and get the treatment to teenagers who need it. Hi, Lisa. Great to see you.
Thank you. Thank you all. So these innovations and these new ideas represent 3 of the inaugural class of awardees of the Yale New Haven Health CHI program. There were 40 plus applications and a process we went through, but these represent 3 that health system leadership and others who externally helped evaluate the companies or the ideas felt as though were valuable and particularly valuable to innovate and to support from within a health system. So with that in mind, Pam, I'm wondering if maybe you could walk us through a little bit how we think about innovation from within the setup of a traditional academic health system. There are a lot of complexities to how we're operating our business today, a lot of challenges, a lot of financial strain, and yet it's pretty clear that what got us here ain't going to get us there as we think about moving forward in healthcare. So I wonder if maybe just talk a little bit about our health system and how we approach innovation.
Absolutely. Thanks, Max, for the opportunity. First, thank you to this brilliant group of innovators, physician leaders who are absolutely changing the trajectory of healthcare. I think healthcare is in this new or challenging space, and we can't go through a healthcare conference without saying the C word, right? COVID just brought to light and expedited what some of those challenges already were. Everything ranging from the financial models that we live under, kind of value-based care, the dissatisfaction with the overall engagement of patients and participating in their care. And so all those signals say, it's absolutely ripe for disruption. And we see that happening in the marketplace, right? We see large players disrupting the traditional healthcare system. And let me say, I have to say, and I'll probably get fired for this, saying appropriately so, right? What we have now is not working. I think historically in the healthcare space, we've been very acute care focused, but care is pushing out into the community and not just into the ambulatory environment, which now is starting to get our healthcare system's attention, but really more importantly, and I think you all alluded to, pushing to home, right? And now not just care being provided in institutional settings, but care being provided in one's home, care being provided virtually, anywhere, remotely available. And so this presents a really important opportunity for health systems who often have shied away from innovation to really find a new space and to engage with partners in a different way than perhaps we have historically done. I would say large academic systems are very nervous about engaging in partnerships just because of the risk as well as the regulatory environment that we live in, which I think is in many ways complicates the healthcare systems ecosystem in a way that's different from, Amazon or from a CityMD or from a more localized business venture that presents some challenges for us. But I think we are now ready for that active participation and engagement in the disruption. I think the participating in the Innovation Awards is just one example of that. What is the pride and joy of academic centers are our providers, right? You all are making the difference in how care is delivered. You're the ones who have discoveries. Our job as administrative leaders is to empower that team of people and bring that knowledge to bear on solutions around some of these really complex problems. So happy to elaborate on some of those challenges, but certainly.
Yeah, no, I think that's really helpful context. And I think it's important to note, just thinking about the categories of innovation that have been described here, it's a mix of inpatient and ambulatory, some degree of automation processes, a lot of focus on evidence-based guidelines and how we implement evidence-based guidelines in a reliable way. Dan, since you're on a little bit of a time crunch, maybe we could ask you a couple of questions, just thinking back to the ideation phase and how you had the idea and why it was helpful to be in the environment that you're in and with the support of the health system. Just walk us through a little bit the very early stages of that, and then we'll bring it back to the idea of why it fits in so well with health system strategy.
So I think one main reason for the success was just the friendship that Dr. Li and I have in the operating room, we're always talking about different ways to improve treatment. Dr. Li is an innovator in regional pain, and she has been making a lot of strides in improving pain control in the hospital. And she had this idea about introducing liquid pain medicine. And at first I was really confused about the idea. I wasn't sure how it would work. But, you know, I see her every day in the hospital, and we're talking about it more and more. And I said, you know what, I think maybe this could work. And I co-teach a class at the School of Engineering, which is a med device design course. And we have a really innovative space there called the Center for Engineering, Innovation, and Design. It's basically a beautiful maker space. And we went over there and we started to build a prototype. And we, probably spent a few months testing out certain things and speaking to our friends at the hospital to get little components to fit into this first iteration. And we got it to work. And
Is it fair to say you're something of a tinkerer?
I'd say we are. And once we got it to work, we were like, this could really work. And the more we showed people the prototype, clinicians, nurses, anesthesiologists, the more they were like, wow, like this is totally different on how we would treat pain, but this would actually really improve things. And that's what sort of led us to submit an application for the hospital system innovation competition, because for us it was sort of a natural thing. We spent so much time at the hospital. A lot of our partners were in the hospital. We had gotten to know clinical engineering really well. We had gotten to know a lot of the anesthesiologists, the opioid diversion committee. All that's happening in the health system, and they were the ones who were giving us all this feedback. So the engineering school was a terrific place to innovate and develop the idea, but it was getting all that customer feedback that was happening in the hospital.
So you two started with an idea and then engineered the solution to fit that idea as best possible, and you're still in that process.
Yeah, I think the most important thing is you don't want to have a solution until you really know the problem. So we spent a lot of time on the ward speaking with the nurses, speaking with the surgeons, speaking with the patients, and collected hundreds of surveys. And based on those customer needs, then designed this product.
So often I think we hear about technologies or advances that are looking for a disease to treat, whereas really you started from the ground up. You started with the unmet patient need and then drove towards the engineered solution.
Correct.
Thank you. Maybe Emily, you want to talk a little bit about how you have gotten to this point? I mean, you've really described a highly accelerated process of developing an MVP, partnering with a giant, and whereas I think some of the other innovations have the ability to kind of stand on their own, you made the very early decision that this would be much faster and much more successful by innovating within existing systems and within existing structure. Totally different approach. Can you just talk a little bit about some of the pluses and minuses in that regard?
Sure. So selfishly, I wanted to solve a problem, and I had a team that was interested in that problem. As a neurologist, so cardiac arrest is the biggest stroke that you can have, right? You have complete loss of circulation. And so having the data immediately available that actually dictates prognosis is extremely important to the neurologist, because if a patient survives a cardiac arrest, it's those factors that are going to help you understand how you communicate with the teams and the family as to what the outcome potential is for recovery. And so the more we talked about these issues of documentation and having immediate access and understanding how we were delivering cardiac arrest care, it became apparent that not only was there an unmet need in documentation, but there didn't exist a solution in the market that could solve our problem. And so the project actually initially started with thinking about developing a software package that could then be sold to a company, right? But the challenges with that would be it would need to be updated as guidelines changed. It would need to have an iterative process that over time would need to be owned and maintained by a group of people and potentially a company. And none of us in the group who are invested in really bedside care and delivering the best possible care we can felt that we had the bandwidth to leave our daytime jobs or to commit away from our daytime jobs to develop this company. And in talking with Margaret and Walter and Lisa, who was instrumental, we felt that as a group this was the best solution to give up the IP to accelerate this process and transform how we deliver cardiac arrest care not only locally, but as I mentioned earlier, globally. And the goal was to not just create an application and deliver guideline-based metrics and ensure that all patients get the highest level of care possible, but was then to create an infrastructure in which we could do QI on a local level and feed data into registries and databases of all partnering institutions that utilize this software to then facilitate team-based science that would feed back into the bedside. So the challenges with that are that we gave up the IP, and our idea is being vetted through Epic, and they've been incredible partners. They're shopping our product to other institutions and getting feedback from them, and what we've created and we feel like is our baby, right, is not necessarily going to be recognized as such. I mean, Yale will be recognized for sure, but as an individual, right, as somebody who crafted that and as a team that really put in all of the intellectual equity to develop that process and really facilitate and push it forward is not lost. But we felt like that loss was far underweighed by the gain of being able to transform the landscape of cardiac arrest care and hopefully develop an application-based suite with Epic in which we could address all sorts of inpatient and even outpatient emergencies into the pre-hospital setting that would then transform brain-centered resuscitation in a way that the health community hasn't seen.
So, and just to dive into that in a little more detail, so you made a big sacrifice by giving up the IP, but consistent with the values of mission-driven innovation and consistent with how you wanted to see the innovation play out.
1,000%.
Yeah, great, thank you. And maybe for all three of you, Amber, you touched on this a little bit when you were talking about your innovation, but there are some challenges with delivering healthcare in an equitable fashion and finding tools that can be deployed in ways that can improve access to care and health equity. Can you talk a little bit about how your innovation expands in that domain, and maybe Jinlei and Emily, if you could touch on the same topic as well.
Yeah, I'm happy to touch on that. Absolutely. And I just want to say, one of the things that I'm seeing and hearing is being very consistent about what you described is that really puts the patient at the center, right? The idea that you would relinquish that IP in order to serve patients, I think is really powerful. So I'm going to do two things. Because I'm from Yale New Haven, I'm going to tell a patient story. And then the other thing that I'm going to do is I'm going to describe measurement-based care just to make sure that I level set with folks what that is. So measurement-based care is the practice of using routine standardized assessment throughout the course of someone's behavioral health treatment. It is not a one and done screening for a new case of illness. It really is using that measurement throughout to then make strategic changes and decisions in collaboration with the patient. And that really is the key that brings measurement-based care beyond screening and even beyond what we might think about as routine outcomes monitoring, where you might serially assess someone. So really the patient empowerment perspective is that it is about what you say is happening in your care, and then we're going to think and talk about that together and use that information to make meaningful changes to care. And so you might be thinking like, Amber, you just said like 28 to 70% of people are dropping out of treatment. Oh my goodness. And while that is true, what we know about measurement-based care is that patients drop out of treatment 20% less when we collaborate with them about their self-reported experience, which is substantive when you're really thinking about that treatment dropout landscape. So to the patient story, a lot of times people are thinking, well, actually, this is not a thought. I think this is just a fact, right? Teenagers are not usually doing cartwheels to come into treatment to see us. They're like, oh my gosh, like we're going to grow old with you. I couldn't possibly. And so people thought, how on earth are we going to get teenagers to take routine measurements, which feels a little bit like a quiz, every single time they come into treatment on a Monday? Well, we did that because we actually made it matter to them. And the way that we made it matter is that we provided them back their information and we gave them an opportunity to really be empowered to participate. So I had a teenager once who came into care and she, we started to see these trends in her scores over time with her depression symptoms, where her scores started to go down slowly over time, and then she had a little spike toward the end of the treatment, and then they kind of leveled back off and went down. And this was a teenager who was literally like, I cannot possibly come to see you. You're canceled. You're the worst. She was razzing me on my Instagram account. And then I found out from that teenager at the very end of her treatment that she printed out her scores and she kept those scores underneath her bed on the side where no one could see them. And she would go and look at those scores when she was feeling discouraged in the treatment because she knew if I can get them down, I can do that again. And that is why measurement-based care is so, so important. So the way that I came up with this innovation is how can we make sure that measurement-based care is happening for every single person who is in psychiatry and behavioral health? Because that is what the research supports. But it turns out it's really hard to do that. It's really hard to do that, especially if you don't have an electronically integrated way to send and capture that measurement data back, or a way that providers can actually see what those scores are so that they can share them in a meaningful way in their treatment. So that's really how I came up with this idea. So I went out to market and I said, and actually I didn't go out to market, Walter went out and did a lot of this diligence and came back, and we interviewed a number of measurement feedback systems on the market. And as we were doing this, we started to get really clear about what the gaps were in the current marketplace. So if I'm like a Rorschach card, a lot of people respond to the ink blot. I respond to the white space. And Rorschach would say that that's like aggression and obstinance, but I think that it is really persistence, and that's really where innovation lives. It lives in that white space. And so what we found is that, wow, these measurement feedback systems are actually not doing the clinical process of measurement-based care. They can get the measurements back, but they're not doing where we know where the impact really lies, which is in that feedback. And so that's really where the ideation came. The short answer is I had this like aha moment in my shower, and I thought, oh my gosh, I have like solved the problem. So that's a little bit about that. And now to touch finally on this piece around equity, what we know for sure in the data is that Black and brown individuals drop out of treatment at exponential rates. So those 28 to 70% rates, populations of color are really toward the higher end of that trajectory. And what we know about MBC is that, well, what we know from our practice-based evidence is that because measurement-based care really turns on ensuring that there's collaboration with the patient, and what we know from Black and brown patients is they say, I don't feel in alignment with my provider about diagnosis. I don't feel in alignment about this specific treatment that you're saying that I need. And furthermore, I don't feel heard in this space. Measurement-based care is a clinical process and a mechanism that could potentially disrupt that pathway. And so that is a lot of what we're putting out in the research now to really try to understand how measurement-based care can disrupt the ways in which we've been doing treatment and really infuse the voice of the patient in the care. So a lot more to be seen on that, but I'll turn it over now to folks to touch on that in their process.
Because I think from the equity standpoint, from the beginning, one of the advantages of partnering with Epic was that far reach, right? And the ability to get care to the patients quickly and in an effective way. And so in order to roll that out at Yale New Haven Hospital, we knew that York Street campus couldn't be the one at the only one at the table. And so we really have made a concerted effort to ensure that there's representation from our delivery networks as we create this application, because the resources available throughout our health system vary from campus to campus. And we wanted to ensure that the application we were developing could be used in any combination of providers at any delivery network. Right, for us, we have probably the most resourced campus, right, with pharmacists and nurses and a whole resuscitation team, but that's not the same throughout our health system. And we wanted to ensure that everyone could use the application and it could deliver the guideline-based metrics that are so important. But then feeding that data, right, the data-driven care into Epic would allow us to identify gaps in resources and quality metrics at the delivery networks, and to provide dashboard data of sorts to each of those delivery networks to help facilitate improving care, but also then to advocate for additional resources as needed to ensure that the care being delivered at each of those campuses was the same, right? So it shouldn't matter whether you land at Bridgeport or L&M or Milford campus or York Street. You should get the same level of care when it comes to post-resuscitation and resuscitative care and brain-centered resuscitation. And so that was really our mission.
And I'm sure ultimately that would be true in a rural hospital as
Right.
well, somewhere that has even less resources than what we think of in a Connecticut-based hospital.
Correct. And one of the things EPIC is doing, recognizing that there's clearly heterogeneity across the U.S. With access to care and with delivery of care, is shopping this around and ensuring that it can be used in multiple different settings outside of an academic health system. Right?
Since I'm specialized in acute pain, I'm not going to talk about the genders, race. Actually, I'm going to focus on the special patient populations. Those are substance abuse users, opioid users. And how I started this is one day I was rounding. I was never be welcomed that much by another team with the patient. She was like, coming in, I'm all down. I'm like, what? So this is just an opioid user, just had a simple ankle procedure, yelling, screaming at the nurse. I haven't got my opioids. This has been 4 hours. Of course, you have to take it for a grain of salt. But this is the patient. No hospital will give them patient-controlled intravenous opioids. Well, unless you put them in ICU, the nursing ratio is 1-3 most of the time, Dr. Laurans, right? We cannot afford any more frequent. The nurse cannot go back to the bed every 3 hours. So how do you handle those patients? And for those clinicians here, nurses there, have you ever had those patients who say, never mind, you're not solving my problem. I'm going out on the street. I'm going to take care of it in my own hands. So this is how we started. The most patients that benefited from this, yes, those patients have problems. They probably did something wrong in the past, but we have to validate their feelings, their emotional needs, their physical need, and we need to figure out how to solve those problems. This is how we started. But of course, we'll benefit all the other patients. And eventually, what we're hoping, we're going to give the patients just the smallest dose possible at the most frequency possible so that we can minimize the chronic pains that are produced by the injuries and the surgeries.
Okay, so Pam, none of these are clearly innovations that are in line with our mission, vision, and values, and we start almost every meeting with some discussion about how what we're working on is consistent with those elements. But none of these are going to solve our financial stress or our financial situation. So how do we reconcile investing in areas that are consistent with our mission, and then simultaneously figure out how we meet our broader commitments to the community by staying financially viable and being able to be a healthy organization?
Yeah, it's a really important question, and I think it's a little bit to Dan's point. We have to make sure we understand the problem we're trying to solve. And quite frankly, the bigger the problem, the more complex the solution, but the more value added it is. And I think each one of you mentioned you had to develop the business case for your proposal. It has to solve we can't add incrementally to the financial costs. And in fact, that's the joy of innovation. Typically, you're finding ways to be better financial stewards of the resources. You're eliminating redundancies. You're streamlining workflows. You're using innovation in lieu of the workforce. Our labor market comprises 60% of our expense structure. And so when you can use innovation and technology and resources or enhance workflows, you really improve what the workforce actually has to work on, and really reserve our human talent only for those things that require the human touch and the human element. And so innovation actually becomes a very important strategy for containing costs, reducing costs, when appropriately analyzed. Now, some of the challenges, the upfront investment. I think what's exciting is that more and more of the work that you all are doing isn't requiring the levels of capital that some of our investments today require. I mean, I often have fun asking people to guess how much the new bid tower that's going up at St. Ray's costs. Just Guess how much that building is. I can't resist. One guess.
$1 million.
Bad guess. 800 of those 1 millions. That's right. So investing 800 million for a building, right? We can't do a lot of those. So investing in technology is a far more efficient way to get some improvements in workflow, to get improvements in the patient experience, and most importantly, I would say, to get improvements in the provider experience. I think what makes it tough, while you all are wonderfully talented and are here participating, oftentimes those strategies are not developed by the people who do the work. And so they miss really important elements of the design that are essential for adoption by those who are doing the work. And so for those who are entrepreneurs, that's a really important piece. You've got to engage that frontline caregiver. And it's not even engaging administration. It's administration, we're not helpful, right? Although you're a neurosurgeon.
Rarely.
Yeah. Most of his day is as an administrator, but it's really knowing how does the respiratory therapist do his or her work any given day. And when you introduce that technology, what does it do in terms of their workflow? Because we're such an integrated care delivery system, you also have to think about the downstream. So, and I think, Emily, you're touching on that, right? What does that mean for the next caregiver who has to now care for that patient? And where do we push out bubbles that we perhaps didn't anticipate pushing out? I would also say, I talk to a lot of investors who are like, how do I get in there? Or entrepreneurs, how do I get in there? How do I get engaged? How do I get my product? How do I get my service in front of people? I think some of the challenges, we can't just solve one problem, right? Because we have to connect, and I really applaud you, Emily, for working with Epic and foregoing your IP, although I don't want everybody to do that. But it has to be able to connect into our integrated health record, and Epic is notoriously hard to get integration, as are the other proprietary organizations. And so while we are adopting new technologies, it has to tie together to a larger platform that speaks across our enterprise. And when you're an enterprise spread over 5 delivery networks, which is just our fancy way of saying communities, it becomes much more complicated.
Thank you. I would argue that the rubric that we use to evaluate these innovations and their worthiness for investment is actually very similar to what we might use in looking at a new product or piece of software. What Lisa Stump, our Chief Information Officer, does on a regular basis with the dozens of new innovations that cross her desk every week to identify how does this make our teams more productive? How does this decrease our per service unit cost? How do we, unless you're actually curing cancer, saving cost has got to be a component of what we're doing in healthcare. There's just too much expense across the board. And so we, I think, use similar framework in identifying which innovations we're going to support and what we want to bring into the health system. I think this might be a good point to open it up for questions. We have 10 or 15 minutes left.
Actually, Max, we have a hard stop at 10:50.
So we have 3 minutes left. Good. Thanks, Jim. So let's open it up for 1 or 2 questions at this point. Yes, ma'am.
I'd love to hear everyone's commentary on data ownership, kind of as we move forward, because patients becoming greater owners of their own data has a lot of potential for impact, but given there's kind of retail players entering the market, there's a lot of historical enterprise level data that can be leveraged. What's the commentary on that whole,
what's the new phrase?
What's coming?
What's the new phrase? Data is the new oil. Who owns it? Pam, do you want to take that a little bit from a sort of system leadership perspective?
Sure, and I say data is the new currency, right? For sure. And I think you have to have, from an organizational lens, you have to have a robust data governance perspective, right? And how you're going to intake all of that data, organize that data, who has access to that data, how's the patient engaged around that data, and quite frankly, and I really appreciated your point, Amber, how do we iterate on that data? Because that data also perpetuates equity issues, which is becoming a bigger issue that is pretty important and near and dear to my heart, because as we think about AI and the predictive analytics space, which is all based on data, it creates some equity challenges that I don't think we have yet fully discussed. But I think data governance is going to be critical. I wish I could say there was like a singular answer, but I think you have to take it into consideration. We are standing up we have data governance in our institution, but really formalizing that in a very different way is going to be critical. And I think as we push care outside of the acute care setting, the patient, and I'll say / consumer, because they're not always our patient, they may be someone else's patient, has to be engaged with and validate the accuracy of the information and have an opportunity to be participatory, especially as it drives algorithms now and drives your care content. So I think your measurement point is really going to raise this issue to a whole new level.
Yeah, I mean, there are an increasing number of large and well-funded data aggregators that are taking hold in the market, and I think it will be an ongoing and interesting discussion as to sort of who ends up owning that data and how we can use it, because there's a lot of really good things that can be done there. So I feel like that's a hard stop.
Permission to ask one more question. I'm responsible for making you all, and you're like, and I'll tell you what. 10:55, you have to promise me at 10:55 we have to get up and get out of the room and not stand right here. Here's my question. Thank you very much for giving your clinical folks access to resources to innovate. I guess my question on behalf of Yale Ventures is, we love working with clinical folks who see patients, because when you meet with investors and you have a KOL in the room who knows what it's like actually, take care of a patient and look at human signal, it's super important. The challenge for us is we do not have access to clinician scientists as much as we'd like to have. So how do you, I guess the question is really for Pamela and Max, how do you square the fact that you're giving them financial support, but we really need some of their time too? They need to be released from their clinical responsibilities. Is there a way for that to happen?
Jim, I will say that there are no easy answers to that question. And I had a mentor who once joked that he was a scientist and a surgeon, and he said, people always try to divide my time. It's 80% this and 20% that, or 60-40. And the truth is that doesn't exist. It doesn't exist in medicine. It doesn't exist when you're really committed to something. And that's true for innovators, for anything. It's 100%, 100%. What you do, you devote yourself to, hook, line, and sinker. And it's a philosophical approach. There are many, many examples in our institution of individuals whose time is supported by the health system to do all different kinds of work, including innovation, administration, education, medical direction. I mean, there are countless examples. I won't give you the budget numbers, but it's substantial. It's not an easy problem to solve. And I would say, look, Dan, we moved this by half an hour, and Dan is off to do a hip and knee surgery today because there are patients that need him. And I'd mention also that we have long wait times that we're trying to work on and improve access for patients. And so we do need to make our clinicians available to help take care of patients as well. These are the challenges that we seek through. Pam joked in terms of getting up and walking out of the room because there really aren't straightforward solutions to these types of problems.
Good answer. You should run for office.
No thanks. This is a public evaluation. Thank you again for having us. This is a real pleasure to be here.
Thank you.
About your time.
about.
I'm excited for that too. Yeah, just give me a guys, I'm sweating. Oh my God, I love your energy. Thank you. I'm going to be doing that pitch at 2:30, so if you... You're going to stand here, leave your mic. Right now.